Becky Taylor is the Director of Continuous Improvement at University Hospitals of Northamptonshire NHS Group, leading transformation programmes across 2 hospitals serving nearly 1 million people. A true changemaker, Becky specialises in turning intent into impact. In the last year alone, her team has driven dozens of quality improvement projects, embedded data into the frontline practice and redesigned pathways to improve patient care. This is Behind the Breakthrough, the podcast where leaders behind the UK's most complex transformations reveal what actually drives breakthrough change. In this episode, Becky lifts the lid on how transformation actually happens in the NHS, what gets in the way, and how to push through to real results. So grab a coffee and let's find out what it takes to turn ideas into impact. Becky, welcome to the podcast.
Thank you for having me.
How are you doing today?
All right, thank you.
Feeling good?
Yeah.
Why did you decide to do this podcast, Becky?
I think we're not particularly good in the NHS at sharing good practice across what works well in one hospital and why change happened and what it was that somebody really kind of bottled into why that worked. And I thought it might be an interesting opportunity to share some of the work that we've been doing in Northamptonshire.
Yeah, I agree. Do you know what? You're right. I think people are quite hesitant sometimes to share good news stories. Often the headlines tend to be, this is wrong and this has happened and this is bad and funding is an issue, etc. But we don't give the positive stories as much airtime. I wonder why that actually is. Why don't people kind of come out and be more positive about it?
I think people are positive. What's more difficult, though, is if you know a hospital down the road has done something really good, what did they actually do? You tend to hear the output of it, but when you get to understanding what change was it that they actually made, it's actually quite difficult, and I think we're less good at explaining some of that.
And do we do that enough? Do we learn from our partners, even within the same region or geography? Do we do that enough?
No, I don't think so. I think it's very difficult, particularly for frontline operational and clinical teams, to come out of the day-to-day to have a think about how to improve what they're doing, never mind go and see what somebody else is doing and build those connections and understand what worked and why and how you could translate it over.
Is that because really it's no one's job to do that? Everyone's kind of focused on the here and now. They have their day job. They need to save patients. No one's given the scope or remit to actually do that investigative type thing, learn from best practice, talk to partners.
I would argue it's everyone's job to do transformation and improvement. So I'm not sure I'd agree with that, but I think how pressured it can be to deliver the day-to-day and look after the patients that are in front of you today gets in the way of creating the time and the headspace to do the other part of the job that actually people get a lot of energy from.
Okay. There's an interesting statistic, which is around 70% of large-scale change programs fail, and they fail to meet their original objectives and the benefits that they had outlined. From your experience, why do large-scale transformation projects, especially in the public sector, fail?
So I think there's quite often not enough clarity about what you're trying to achieve and why. Therefore, you don't necessarily understand what it was you were trying to do, which means that you kind of by definition haven't met what you intended to do because you weren't clear enough on what it was to begin with that you were trying to improve. I think in the context of people who are really busy, it can be really difficult to engage people in something that is often not necessarily quick. So they have to put some time and effort and energy up front to have a think about how things could be different. And it doesn't feel as important or as urgent as dealing with the patients who are coming into A&E today. And so making sure that that time is spent with the frontline people to design something that will work for them, it's quite hard to get to a place where they're creating that time and they've got that headspace and they're able to step away from the clinical space in order to get into the right mindset and then design what the future looks like.
So you're almost describing what is urgent gets prioritised over what is important, which kind of creates this, we need to focus on the short term, we don't have time to focus on the long term. Is that a people thing? Is that because people don't have the headspace? Is it because no one's been given the role to do that? What's the crux of that problem?
So I think there's definitely a headspace, time, pressure. You know, there's a lot of targets. There's a lot of patients in A&E, there's a lot of patients waiting on waiting lists, and dealing with the immediate, how are we going to deal with the patient where somebody showed up sick and we've had to cancel their surgery next week and they're going to breach 65 weeks always feels more important than the kind of longer term, what will make it so that in a year's time we have less 65-week patients that are waiting in general. I also think that people don't necessarily like change. My whole job is change, but I don't like it when somebody tries to change me.
Yep.
So like taking people on that journey takes time. You have to do it in the right way, and people have to feel engaged enough and part of the change enough that they don't feel like you're doing something to them. But then equally, that also takes more time away, and you can lose people along the journey of that to say, oh, well, this isn't really making any difference, or I've been given this new tool and the data's wrong in it and I don't trust it. Like, there's a lot of different points at which people can kind of divert from the path of what you're trying to achieve for various different reasons. And keeping people on that path of change as they go through a change curve can be difficult, and you need the kind of leadership will to do that. You need somebody's direct line manager to give them the time to engage in it. You need them to be in the right headspace when they come in the room, and then you need people who've got the skills to help people on that journey, and then the tech that supports it.
Yeah. Do you know what? When you were speaking, someone came to mind. People don't like change; they like you to change, which is kind of reflective of what you're saying. If we almost go back a second, what is change? What is transformation? It's a word thrown about so often, especially when it comes to the NHS and big programs. What is change?
I think probably different organisations have got different balances, which is probably dependent on their local organisational context and history. So if you go too far to the kind of continuous quality improvement, you're never going to make the big change. If you take something like looking at how do you improve clinic admin, we could do all sorts of things where we process map and understand the different steps of developing a clinic letter. And you could continually improve that, and we could probably take some of our specialties from having a delay for making their clinic letters of 4 weeks to 2 weeks, 2.5 weeks, something like that. Or you can completely disrupt the way that works, and you can implement something like ambient voice technology and completely disrupt the way in which that process happens. And there's a place for both, and there isn't always something that will completely transform the way in which something works. So I think you do have to have both. Mm-hmm. And I think sometimes you get big leaps in technology or big leaps in thinking that mean that there are more on the completely disruptive side. But you will always have frontline staff who've got great ideas that will make small improvements locally, and you have to find a way to encourage them as well.
Do you think the NHS is too risk averse?
I think there are pockets of it that are, yeah. It can be really difficult, can't it, in an environment where there's a lot of regulation. You're talking about patient safety in a lot of cases, but unless you try, you're not going to change anything. Mm-hmm. And as long as you've got appropriate safeguards in place when you're making changes happen, it's normally a good thing to do. We have examples where we've changed things and we've got metrics in place that help us to understand whether or not it's a good change or not, and they've gone in the wrong direction, and so we've undone a change. That's the way in which you should operate. Like, you're never going to learn something unless you try it, but you need to make sure that you've got the mechanism in place to learn and then are able to undo it if there's a problem.
Okay, so change is necessary, important, inevitable, but it's hard to change in the NHS, given it's big, complex.
It's big and it's complex, and you're trying to change. Like my organisation, we have 12,000 people who work for us. We're trying to change the way in which 12,000 people work. Like, think of the way in which a ward team works. You can go into a ward on a Monday and you can be having a conversation about how we can make a board round work more effectively to discharge patients. And there might be 10 colleagues there on the Monday who are at the board round. And if you stay around afterwards and you're there for the day shift, there's probably 30 colleagues or something. You could come in the next day and there'd be 30 completely new people there. So then you have to work with them And that's before you get to the people who only work on nights. And unless you think creatively about that, you're never going to get in front of them to help them understand what their part in making sure that the morning goes smoothly is. So even just in the context of like one team on one ward, it's quite difficult to kind of engage all of those people effectively. And then, I don't know how many wards we've got in our hospital, but it must be about 30 or 40 between the two sites. And quite quickly, that's an awful lot of people you're trying to change.
That nuance is super insightful. And I think potentially we try and apply quite a broad brush when we talk about changing the NHS. Where are examples where you've seen it work really well and where you've seen it work not so well?
So I think it has to come back to designing things with people rather than... And I realised in the last bit I said if you're trying to change people, which is what we were just talking about not wanting to do. So we are currently doing a piece of work where we're trying to make it easier to do all of the actions to discharge a patient after a board round earlier in the day. Because we know that if we move the average time of discharge forward by an hour and a half, that will save us the equivalent of 34 beds, which won't actually be saving 34 beds. It will be 34 people in our emergency departments who are waiting for a bed who we can put in a bed sooner. So we've tried to do this as an organisation for a long period of time. But at the moment, we have 4 resident doctors, we have a pharmacist, we have somebody from pathology, we have a couple of keen ward sisters, we have some of the porters and people from the discharge team who are actively testing and kind of trying a new way of how do we line everything up so that it all makes sense. So, really silly example, the pharmacy team arrange their lunch break so that they go for lunch between 1 and 2:30. But that's about the same time that the resident doctors are finishing, they've done all of their tasks with their sick patients and they're just at the point where they're doing their to take away things for the pharmacy team, but that's the point at which they go down to half staffing. So how can we reshuffle the way in which things work so that we don't go down to half staffing at that point in time? And is it easier for the resident doctors to do that earlier, or is it easier for the pharmacy team to move their lunch? Because then there's a series of tasks that happen after that. And getting everybody in the room to design that has been really interesting because people hadn't realised there were all these kind of micro clashes in the way in which things work. And if we design that well, we've designed it in such a way that it works for people's current working patterns, but yet works better overall, which should then mean that it should be easier for us to roll that out across the other wards because we've got the same pharmacy team and the same pathology team, and a lot of the resident doctors are shared across multiple wards and multiple specialties. And then the teams on the wards, they're really keen to use this as an opportunity as part of their kind of personal development to share and learn that across the other ward teams. So we've got a group of people that are kind of passionate and they've designed that in the way in which it works for them. Well, that's going to be much better than something where we say, well, why haven't you discharged your patients before midday? Get your drugs in earlier.
That is such an interesting example and quite surprising because sometimes you think of change and transformation as these big tech programs or these big initiatives that come in, and what you're talking about really is a small change in someone's shift pattern and therefore that unlocking a cascading series of benefits over time. What's the process you go through to even identify that that's a blocker?
So I think you have to listen to the people who know the way in which they work better. So we have a few different ways in which problems come to my team. So anyone who's got an improvement idea can come straight to our team. We try and advertise it to the organisation so that people know who we are. When people join the organisation, we tell them who we are. And so if someone's got an idea, they will come to us and they'll say, I really want to make this work better. And then my team will help support them with that. There are some things that are strategically important enough that we look at them through a kind of transformation lens. So we will have some data that we analyse and we say, look, this is a problem and we need a programme around it. And then we do some deliberate kind of process investigation around what those problems are. That particular example came from something we did before Christmas, where we did an improvement week, where we took it 3 days, and I have had some feedback that 3 days is not a week. But we took 3 days, and we aimed in those 3 days to go out and speak to people across the organisation on our inpatient wards who would. My team were in some very fetching lime green t-shirts, which got compared to a supermarket delivery drivers. But they were out and about on the wards. They were recognisable, and we said, "Tell us what your problems are, and what your ideas are to fix them." And we went out onto the wards, and we had over 400 ideas back from frontline staff. So resident doctors, portering teams, domestics, ward clerks, nurses, HCAs, everybody, around what would make working on wards better. And this was one of the things that came out of that. And through that process, we also got the people who were really keen to make it better. Some of the people who came forward with an idea sort of said, I've got an idea, but I don't want to be involved going forwards. But these people really wanted to work with that. So we identified a couple of wards to work with off the back of that. This came up on the Tuesday. By the Thursday, we'd already had a working session with people and sketched out what did the work look like and how did we need to make that work, so we could, who else needed to be involved, so we could get them engaged in it as well.
Wow, so you made it, that is so interesting. So you made it really approachable. So there's a lollipop man or woman kind of standing there, I'm here to help. And then people are actually flooding you with ideas and actually being vocal evangelists for those ideas and being part of that change. What was the key to success? Was it actually just making yourselves really accessible? Or was it your reputation, the fact that you guys actually genuinely help and carry through with the change? Like what made that week work in particular, or 3 days?
3 days. So I think some of it was definitely physically being there. And I'm very grateful. So we did this over December and January. I'm very grateful for the time and energy that people spent talking to the team about what could be better at what is probably the busiest time in the year. So that, very grateful to people that they took the time to do that. There's definitely a proximity thing within that. Like sometimes I think within, if you're working on a ward, the teams that are there to help, that are kind of corporate teams, can feel quite distant. And I think that proximity and bringing people to the same place, I think, was really helpful. We were really clear that there was a no blame, like no idea is a stupid idea. And there is no blame. We just want to understand what's happened. We want to understand how often something happens, and we want to understand how much, how it could be better and how much time could be saved either for staff or for patients within that. And I think that was really helpful because there were a number of people who raised something where they sort of said, well, we've heard you've said it's a no blame thing, and kind of understanding that people aren't coming to work trying to do a bad job, but there's probably something that the other team are doing that you didn't understand about, and that kind of spirit of curiosity, I think people enjoyed. And then I've got a fantastic team, and some of them are very well known in the hospital, and you can't walk down the hospital without somebody stopping to say hello. So I think there is a degree of kind of organisational respect for some of the colleagues in my team, most of the colleagues, if not all, in my team.
Wow, that's awesome. And being a visible leader of change.
Yeah.
Being visible.
Yeah.
How do you get change where people don't even see it? People don't realise the thing that they've been doing for years, decades, is wrong. What's your approach to that?
So I think there's a few things. So sometimes the data will tell you that. And we find that sometimes. So particularly where you've got benchmarking information. And this is where the power of programs like GIRFT works really well, because they can assume... GIRFT. Getting It Right First Time, which is a program set up by NHS England, which is intended to reduce clinical variation. So they have a set of data across a range of clinical outcomes, and they're able to show it to our clinicians and say, did you know that your day case arthroscopy rate for knee surgery is much lower than other comparable hospitals across the country. And then that can be a way in which clinical teams can have a look at it and understand, okay, we're doing something different here. So that can be one way. I think sometimes people don't realise that what they're doing, like the world's moved on. Sometimes you don't, because you're kind of head down and having a think about it. One of the things we tried to do is spread improvement across different teams and different wards, and that's surprisingly difficult to do. Like you were asking me earlier about how do you share change across the NHS. It's surprisingly difficult to do even between two wards in the same hospital, or two hospitals, my two hospitals that have got the same leadership team, never mind across the NHS. Which is why I was saying understanding what practically people changed and creating a bit of a toolkit around that is really helpful. So we had a nurse in our infection prevention control team who did a chief nurse fellowship. And as part of that, she did a project where on two wards in Northampton, she changed the drinks so they were decaffeinated. Sounds like a really simple change. And by doing that, she reduced the falls on those wards by 32%.
No way. Really?
She reduced the incidences of violence and aggression from patients with dementia by 50%. Massive change. Wow. She'd picked it up because there's some research about it. So it's a thing. Yeah. I was surprised as well. And I think she was really surprised by the impact of it as well. It's won one of our quality improvement projects at our Quality Improvement Awards. Fantastic piece of work by Jasmine. Trying to get that spread across just Northampton, never mind Northampton and Kettering, has been really interesting, because you'd think that would be quite straightforward. Make one change in the catering department. So we have now spread it across all of the wards in the group. But it's really interesting, because making a kind of test change in one area is quite different to changing organisation-wide hospital policy. And that's in a situation where you can make one change centrally, rather than something where you're asking lots of people individually to change.
Wow, that is such a fantastic example. When we're talking outside of these podcasts, we're always talking about big transformational change, step changes, but actually almost all of your examples are the small, like ripple effect type changes, small changes that have absolutely phenomenal impacts. That caffeine example is just fantastic. You've given some incredible examples of small changes that then ripple or snowball into big, proper transformational changes. And the technologist in me wants to ask about technology and how that's affected it. But actually, it's just so interesting that there are kind of small process changes that you've found. If you were to bottle up how you are successful, how would you describe that? So if I was to say, how do you identify a particular change that needs to happen? What's your process, your methodology that you go through to identify change?
So I'm a real believer in data-driven improvement. I don't think that you can know that something's a problem unless you've got something that tells you that it's a problem and how big of a problem it is. So definitely starting with the data. Now, sometimes you've got the data and it's already there. Sometimes you can engage people and they think it's a problem, and then you can help them through coaching methodology to identify and quantify what that looks like. You might do an audit, you might do some time and motion studies, that kind of thing, to try and identify how is it a problem, how often does it happen, how big is the problem, and is it worthwhile spending the time and the resource to fix it, recognising that there isn't an endless pot of change resource in the world. So there's definitely something around using the data to help with that. Engaging people in what that looks like. So because I manage both quality improvement and transformation, we use a lot of the same tools across both in terms of process mapping, root cause analysis. They are shared between our QI projects and our transformation programs, which I think is helpful in terms of thinking similarly about how you map processes. So what we sometimes find is something will come up as a small change that somebody's keen on. We'll do some of that process mapping, and it turns out it's a bigger thing. And so then we have a wider session, and that's when we start to bring in my transformation team who do more longer term kind of programmatic changes, or we might identify a small process that we can change, but actually there's something bigger we could do here if we implemented tech or changed in some way. And similarly, that happens the other way around. Sometimes we'll have transformation program around length of stay, for example, and we deliberately push some of it towards quality improvement and look for people who are keen to lead that locally and then coach them, rather than putting central kind of program resource against it. So there's definitely something about having a similar methodology that lets you pick, depending on what the problem is, what's going to be the best route to tackle it.
So quite simple, actually. Look at the data, talk to people.
Yeah.
You'll find out what's wrong.
Yeah.
Then the next bit is, how do you make the change? So you talked a little bit about you need to involve local people, local stakeholders. What else is there that needs to be done to make that change real?
So I think being able to describe what is it that is causing whatever the problem is at the moment, and doing that quite specifically. But I think one of the tricks is getting the right people in the room when you're trying to design what could be better, so that you've got the expertise that you need. Now, sometimes that might be involving the digital team. Sometimes it might be getting somebody from another specialty where it isn't a problem to come in and help understand why does that work differently. Sometimes, and going back to the getting it right first time team, that might be somebody from another organisation. And I'm a big believer in learning from what others do, because most of these problems have been solved by somebody somewhere else, and it might be slightly different, but there's definitely things that you can learn.
Yeah.
Be careful when you do that, because people don't like it if you try and implement something that's from somewhere else. And I think working in a group model, you have to be particularly careful of that. Yeah. So you have to bring the best of that together to create what's the UHM way of doing something.
And can I just check something? So you said bring the right people together. Who are the right people? So
depends what the problem is.
Yeah, because sometimes people almost tend to bring everyone in the room, like whoever's involved, even kind of tertiarily involved, bring them in and get their views. What do you mean by right people?
So you have to have people who work in the process day in, day out. You have to, because otherwise you don't understand what it is that people are trying to achieve, and they don't feel part of the new thing that they're going to be doing every day. I think you have to have somebody with authority for whatever process it is that you're doing. So if we were going to dramatically change the way in which we do theatre scheduling, I would need somebody quite senior within my surgery division to be involved and engaged in that. They might not be throughout the whole piece, but when we were deciding a new way of working, they'd need to be there, because they have the authority to say, yes, we are going to change this and we expect you to work in that way. And then beyond that, it depends who's been engaged. Who's involved in the different steps of the process. So some processes will be very contained within one team, and other processes you might have an anaesthetist involved, or you might have sterile services involved, or so it will depend on where the inflection points are within that process as to who is going to help and add value to that conversation.
Okay, so following it so far, we've used data, we've spoken to people, we've identified the problem. We've done the cause and effect analysis, theory of constraints, etc., to go, this is the specific thing we need to change. We've got the right people in the room who are involved in the change, decision makers, etc. How do you make it happen? What's the next bit?
Well, hopefully you've come out of that with, this is what we're going to do. This is what we want the new way of working to look like. And then it depends how big a change that is from the current way of working. If it's change the drinks from caffeinated to decaffeinated, that's quite straightforward. You can go away and you can do that quite straightforwardly. You probably need some sort of approval, and then you make the change. If it is changing the way the administrative model works, enabled by tech, and centralising that so that patients have a single number to call, and it doesn't matter which department they're trying to get through to, they just come into one place. That's obviously a much bigger change. So that's where then, from a transformation program perspective, we start to bring in some of the program management methodologies, dependencies, risks, and really mapping out what does the next, 6, 12, 18 months worth of work look like. At which point, if it's a large complex program like that, that's the point at which we will very deliberately involve corporate teams. So we'll probably involve HR, we'll probably involve finance, we'll probably involve digital, sometimes estates, to really make sure that we've understood, okay, if that's what we're aiming towards, have we understood all of the things that we need to do that sit underneath that and the timescales that are associated with it? Because then that's where it gets more complex. So although the kind of underlying principles of identifying and understanding the change and designing the new way of working are the same, we do find a split between kind of the quality improvement where you can kind of coach and support people to do locally, and then the large big change programs is where we then bring that wider programmatic methodology, central resource, and kind of manage that all the way through. We had a really clear strategic direction that said we need to do this for the benefit of patients in Northamptonshire to bring our overall wait times down and make sure that if you live in Corby or Daventry, you wait the same amount of time for treatment. And we had, good tech that helps support that process and make that work really, really well. So I think that's a kind of really good example of where it works well. I have also seen where a kind of bad process is digitised, and I don't think that works. So whenever we try and implement a piece of digital tech, we try and have the discussion, and my team are now increasingly working much closer with our digital team in order to make sure we're doing this more kind of robustly or routinely, but make sure that we aren't just digitising a process because that's the way in which the process has always been done. To make sure that when we've got a new piece of tech, we're teaching people in the context of the new way in which we want them to work, rather than just press a button, click here, do that.
It's not digitising for the sake of digitising.
Yeah. And like transformation and improvement is what you're trying to achieve. You're not trying to achieve digitisation. And I realise there's a lot of NHS kind of funding, and analog to digital is one of the 3 shifts, and kind of transformation isn't. But digital is a way of enabling transformation. You can transform and improve processes without changing anything at all from a tech perspective. Tech, I think, takes it to the next level. And I think sometimes we kind of forget with what is the problem we're trying to solve, and why will it be better, and how can tech support that, and how do we best incorporate that in a way in which people's day-to-day experience needs to change, whether that's a patient or a staff member. And some of that is related to tech, and some of it is the way in which people behave and the process that they're trying to follow.
Yeah.
And all of that kind of stuff.
What would be the 3 things, or what would be obvious pitfalls that they could fall into that you would want them to avoid as they go about doing this digital transformation?
Not engaging with the people who don't use the tech, because the tech's not there yet, but not engaging with the people that are doing whatever it is that the tech is trying to help. Not understanding enough what the problems are with the way in which people are working at the moment, and also not understanding what the art of the possible could be.
What do you mean by that? That's interesting.
So to your point earlier, people don't always know that what they're doing isn't good.
You got a good example for that? Could you bring that to life?
So we have a problem at the moment that we are trying to think about. How do we best manage queries for patients who come into our outpatient contact centre and call up and they want to rebook their appointment or whatever? We can't afford to buy what I would have seen in my very brief period when I worked in a call centre, which was a CRM. We can't afford to buy I've got no idea what CRM stands for, so don't ask me, but we can't.
Customer relationship management.
We can't afford to buy one of those pieces of tech that kind of big call centres have that manages all of your call queries. Yeah. So we've been having a think about what could we possibly do in order to do this, because we're going to need something that helps us make sure that we're not creating a situation where the thing that patients hate, where they call up and they have to tell their story again, we're trying to not recreate that.
Yeah.
And we've also got a piece of tech which we use to manage our waiting lists, which has got a list of all of our patients in it. It's got a list of all of the appointments that they're booked in for. And then there's a list of comments against it that we can input comments against. So our validation teams use it to validate, does this patient still need to be on the waiting list or not? Our theatre booking teams use it to say, have we booked this into the thing? And so I'm thinking, well, maybe I've got a list of patients, I've got a list of appointments, I've got a list of comments. Maybe that's a solution that we could use in order to manage that. But if you talk to the teams, both my internal teams who use those existing solutions and the tech team whose solution it belongs to, they haven't thought about that. And so the initial response you get is no. But if you break down the different functionality that sits underneath it, it's the same functionality. Anyway, I've sort of forced my way into that conversation, and we're now going to do that. But we were in a discussion with the IT team who manage telecommunications about how do we manage telecommunications. And over here, we're in a conversation about how do we manage patient lists, and kind of bringing those two different ideas together. Sometimes you need to think a bit outside of the box rather than the kind of USP of the digital product that you think you've got.
That is a really interesting example. So the technologists are almost doing themselves a disservice because they're kind of seeing their solution really myopically, it can only do this thing. And then also you're almost talking about, let's look at what we've got right now. You don't just have to go out and buy the next new shiny thing every single time.
Yeah.
Let's reuse, repurpose, reconfigure what we've already got.
And I think given how difficult it is in the NHS at the moment in terms of finances, like, you've got to be creative. You've got to think differently. And it might not be the gold standard solution, but if it's bronze, why not go for it?
Oh, I love it. You haven't talked about the stick much, and I assume for change there's a carrot and there's a stick. In what scenarios do you need to kind of bring out that stick, use enforcement and other tools to make sure that people actually make the change that's required?
So we do hit a point of comply or explain is perhaps how I would probably describe the use of the stick. If we have the data that says it's a problem, we've engaged people in what the future could look like, we have some evidence that there are some services where it's having a benefit, and then we have other teams who, I mean, it will be for a variety of reasons, are not engaging in the same way. We do go to a point of kind of comply or explain.
Mm-hmm.
If there's a standardized, agreed way of doing something, we've got some evidence it's the right way of doing it. Come to a forum and explain why you think it doesn't apply to you. And sometimes teams come with brilliant reasons as to why it doesn't. Sometimes teams have got kind of complex things going on. You know, there might be a series of vacancies within the team that means it's not the right time for them. Like, fine, we can come back to you at a later date, but you're not leaving the room until we've agreed when that later date is and what that criteria is when you're then feeling more stable as a team. I don't think you can let people, for things that are really important, that you're doing for a good reason and you've proven have impact and benefit and would benefit the organisation and patients, I don't think you can just leave people to say no. It's not optional. You wouldn't do that with a piece of patient safety legislation. So why would you do that with a change that could benefit all of the patients on our waiting list? But you have to have made sure that you've done all of the right things before you get to that point, because otherwise you're putting them in an unfair situation.
Yeah.
And you're not doing that with integrity. Like, I would feel really uncomfortable asking teams to do something where we haven't done everything that we can as a team and we aren't confident it's the right thing to do.
Can I ask you a question about the 10-year health plan? In the 10-year health plan, it says the NHS is at a crossroads and it needs to reform or die, quite stark. And the key to transformation is science and technology. Now, based on our conversation so far, almost all of the change and dramatic change that you're talking about is not technology related, it's process related, it's behavioural related, it's kind of small changes. Do you agree with that statement? And to what extent do you agree with that statement?
So I think improvement is a science. So I don't know that I think it. I don't know that I think they're completely incompatible. There are lots of changes we've made that you couldn't do without a change to technology, and I don't think you're ever going to get the big shifts are more often enabled by tech than not. In terms of making outpatient appointments remote, if I think about reforming the way in which outpatients as a care setting operates, a lot of what our clinical teams describe around why they bring people back on a regular basis to our very busy hospital sites where people have to pay for parking and all that kind of stuff, a lot of that tech will solve. So I am worried about them. What if they deteriorate? How do I understand what their ongoing condition is? A lot of that can be solved by remote monitoring, by engaging patients in their health using digital platforms in a way in which you simply couldn't do without that. So I think the big shifts, yes, absolutely, they do have to be tech driven, but equally, none of that will work unless the clinicians engage with it. We could have the most wonderful set of digital solutions in the world, but at the end of the day, it's the clinician who is receiving that referral and deciding to do something with it. It's the clinician who is sat in front of the patient and is setting their expectations around what's going to happen with their care. It's the clinician who needs to feel comfortable saying, I'm all right if you go and you input your patient health details into the app, and then I'm going to remotely monitor it, and I don't need to see you. They need to do that. They need to change the way in which they work.
It's interesting. Something that's often said in the health tech sphere is the NHS doesn't have a technology problem, it has a technology adoption problem. Meaning, actually, the tools and services exist, but how you get the behavioural change, the process change in order to make it real and happen is actually the secret to actually making it a success or not. So that talks to kind of what you're saying.
Yeah, and I think we have some clinicians who are so keen on some of this stuff, and so I think there's two things. I think there's a group of people who are very keen, who I could pick them out in our organisation, and they are pushing and challenging what are the things that we should be doing, and we can't keep up in terms of, we've just implemented kind of ambient voice technology in some of our clinics at the moment, and we've already got some clinicians pushing further on, well, how can we go further on other emerging tech
And
work.
just to pause, ambient voice technology. For our viewers, I do know what some of these words are.
So ambient voice technology is AI that listens to the consultation between a patient and a doctor. So it will listen to the conversation, it will write the letter if you need to be referred on to someone else, it will fill out the referral. So it deals with a lot of the admin, and it means that the clinician doesn't need to be sat there typing notes, they don't need to do the dictation, they can kind of fully concentrate on the patient in the consultation session. Fantastic clinical feedback across the country, and it's one of the kind of big digital leaps that's been made in the last 18 months or so. So we've got a set of people like that who are super keen, who are then really pushing forward on, how can we do more of that? And then you've got a set of people who've tried it, but it's not necessarily integrated into all the different systems. And I think one of the problems we have got in the NHS is you've got your kind of standard EPR, your electronic patient record, where most of people's kind of engagement from a clinical perspective will be with the EPR. But then the more bits of extra tech you add, you're asking people to go into multiple different systems. So you could have a clinician who's logging into 6 different systems. So if we were to get something whizzy that does some tech thing, that's another system for them to open. Mm-hmm. And so there is a point at which that becomes a barrier to people adopting things. And our digital team are really focused on trying to consolidate the number of systems that people need to log into. But there is a challenge in that, because emerging tech, almost by definition, isn't built into the kind of big, kind of traditional clinical systems that exist.
People assume senior leaders are loud and fast and bolshy, but you've described yourself as a bit of an introvert. Talk to me about how you lead your teams, describing yourself in this way.
So I think when people meet me, they assume I'm an extrovert because I'm quite chatty, but that doesn't mean that it's a lot of effort for me to be with other people and be sociable in that sort of way. I once did one of the MBTI assessments, and I did the one that breaks it down underneath. And
Sorry, MBTI, I'm not familiar.
Myers-Briggs.
Right.
I don't know what the TI
It's like a personality test.
Yes, it's like a personality test, and it sorts you into categories of how introverted or extroverted you are. Do you like a plan or do you like to wing it? Do you make decisions based on logic or feelings? And I can't remember what the fourth dimension is, but that sort of thing. And I always come out as an introvert on it. But I did one once where it broke down the different levels that sit underneath it. So there's kind of 4 categories in there. And one of them is easy to get to know. Like, how easy is it to get to know you? And I'm extremely extroverted on that and very introverted on all the other ones that sit within it.
Talk to me how it manifests itself in the real world. Like, how have you kind of overcome it? Because you're a senior leader making massive transformational change. Like, did you have a bit of imposter syndrome? Did you ever overcome any challenges, or have you just made it part of your personality?
So I think I have to take time away from myself to recharge when I've spent a lot of time engaging with people. It's really important for my job that I spend time with people and understand what their problems are. I find it easier to do that one-on-one than I do in a group. I really hate public speaking. This is the second time ever that I've been filmed, and I'm feeling anxious about it, but we'll go with it.
You couldn't tell, genuinely.
I have taught myself to be better at presenting. When I used to work in consulting, that was a really key part of the job. And consulting can be a bit more brutal in terms of feedback than the NHS. And so when I went through training at my first consultancy firm, one of the things that we did was you had to stand up and do a presentation with no filler words. So no hesitations, no pauses, no cool that sat within the presentation. You can tell I'm not doing well at not putting filler words in now that we're talking about this. And I found it really difficult. I don't necessarily have particularly open kind of body language. And so the person who was doing the training at the time, who was a good friend of mine, and she was kind of my development mentor for a while, asked me to do a kind of superwoman pose while presenting. So did the whole of the rest of the presentation for about 20 minutes, stood like this, in order to get my posture in the right place and be thinking in that sort of way. And then I had an objective to present every 2 weeks in front of the whole company for about 18 months. And it was a bit of a baptism of fire for someone who hates public speaking, but I'm actually very grateful for it because it sort of taught me how to fake it till you make it in terms of feeling confident in some of those situations. And I've now presented on so many different topics. Some of them I knew better, some of them I knew less well. And so that makes it easier now if I'm thrown into something to be able to come across like I know what I'm talking about. My team are extremely surprised if I say to them that I hate speaking and I hate presenting, because they didn't see that before and they don't see now that I find it difficult.
Do you think we'll be in a state in 10 years' time where that is truly embedded and the culture across the NHS, where everyone is motivated, incentivized, actively thinking and doing transformation constantly, or will we not quite get there?
I'd like to think we would. I think there is more of a recognition of the importance of improvement within the NHS. So some of the work that NHS Impact has done, I think, elevates some of that importance of getting improvement right within an organisation, and getting that culture of improvement right, because that is something that enables everything else. And that's one of the reasons why we did the improvement week that we were talking about earlier. all I want is people talking about things that could be better. And that for me is a win. Because if they're talking about it, they're thinking about it. And whether my team know about it or not, some of them will go forwards and will think, oh yeah, I can make a change there. I can make something different. I can, ask my manager if we can change the way in which we do something. And like, that's the way in which everything gets better. Yes, there are some really big changes that we can do, but if you've got everybody working in a way where they're thinking, how can tomorrow be better than today, then tomorrow will be better than today.
Becky, thank you so much for sharing so much knowledge and insight that you've gathered throughout your career. It's been truly inspirational. There's so many things that I've learned from this podcast. Change is not just a job title, it's everyone's responsibility. Transformation doesn't always mean big bang change. It can mean something small, like changing a caffeinated tea bag for a decaf, that can have a massive monumental impact. And finally, if you want progress that lasts, be visible. People on the front line have the ideas. It's about being an authentic instrument for change. That's it for this episode of Behind the Breakthrough. Thanks for listening and being part of the conversation. If you liked what you heard, give us a follow, share it with someone curious, and stick around. The next one might just surprise you.
Okay.
All right. How you doing, Becky? This is how it's going to be.